Hi, my name is Helen Harrison. I'm the Performance and Improvement Lead with the Therapies and Orthotics Directorate at East Lancs Hospitals Trust. I'm a physiotherapist by background. I've been in the NHS for over 20 years. I'm not an analyst and I'm certainly not technical. I'm going to talk to you today about my demand and capacity journey, but also how we've used a sustainable waiting list tool to inform our service redesign. So the area of work that we're focusing on today is the community-based integrated therapy teams across the 6 localities within Pennine, Lancashire. The integrated therapy teams comprise occupational therapists, physiotherapists and support staff, and we cover a range of patient groups such as patients who've fallen, the frail elderly, those who've got neurological conditions. We also work with a number of health and social care partners. Each of the 6 localities has slightly differing demographics and therefore slightly differing demand. The teams have historic staffing levels from when we were brought together a number of years ago to create the integrated therapy teams, and we started using EMIS for our data collection a number of years ago, and more recently as our electronic patient record. So my journey, how it all began. In October 2016, I moved from a clinical team lead role into operational management, and that's then when we started to do some early demand and capacity planning. At the time, the reason we needed to do this was we had very long waiting lists. We just weren't meeting the referral demand that was coming in. Things were growing and becoming a problem. So we attempted to do some early modelling in Excel, trying to forecast if we were going to be able to reduce the waiting list with any of the initiatives we were putting in place. The tool required the clinical staff to input into it. We did have some poor understanding and therefore poor engagement with it. So early in 2017 we started a service review. We started to talk about capacity and how this is defined. We did lots of work on defining capacity by band and by role of staff. We were introduced to the IMAS tool by our divisional analyst, and it was like learning a new language. We were having to understand about the data that our analysts needed. We were struggling to have our data in the correct form for the tool, which made things difficult. The other challenge was we were using the outpatient model, and obviously we're a community-based service, so we're trying to squeeze it into something that we're trying to make it fit. So moving on from there, in 2018 I was lucky enough to be granted a place on cohort 2 of the NHS Improvement Demand and Capacity Train the Trainer course, which was such an eye-opener, and it really started, at the penny dropped, it really started to help things make sense. So my key points from the course were to understand my demand, to look at how do we manage our referrals, and what should our capacity be. So looking at demand first, our variation and our urgency were important. We needed to review it not just as a service but also by locality, because we knew we had the locality differences. The original modelling we'd done hadn't actually taken urgency into consideration, and we had 2 referral streams. We had an urgent stream and we had a routine stream. Second point, looking at managing referrals, there was certain things we had to consider if we're thinking about the parameters section of the tool. We needed to consider our rejection rate and, more importantly, our DNA rate. We weren't managing our DNAs very well, so we needed to get a grip on that. Thinking about capacity as well, so we had an understanding of what we thought our capacity should be, so it gave us a baseline to work from. We had done some work on weighting our capacity based on staff band and role, so we needed to do a bit more with this. So our community therapy team was still struggling to meet the demand, and waiting lists were continuing to grow. So I decided to remodel with the core model when it was introduced, and I felt we needed to have an idea of what our sustainable waiting list should be. But before, I needed to understand the type of demand we had and make sure we had a good understanding of the response times that went alongside that. So in our service, we have an urgent response time of 5 days and a routine response time of 6 weeks. So when we started to collect and input the data into the model, we were struggling with our data coming in a monthly format. The tool needed it to be in a weekly format. So I think I remember at the time emailing Keith about this one and saying, how can we do it? I think he recommended us doing some divisions by 4 or 5 to kind of, so we did this, but it didn't make the SPC tool look right. But at the time we were less bothered about this. We just needed to get the data into the tool so we could look at, have an idea of the waiting list. We did some manual reviewing of our data by urgency. So we had to understand our percentage splits, urgent to routine referrals coming in. We had a good understanding of what the operational capacity should be in our teams. We'd done loads of work on this previously, like I've said, but we had to understand that the staffing may have changed. So we did some staffing reviews, make sure the staffing was right in each service, and that we had the capacity weighting right as well. So for instance, some of our band 7 staff didn't see as many patients as our band 6 and our band 5 staff. So we needed to make sure that was all right. And then finally, the parameters section, we did have our DNA and cancellation rate, but we weren't implementing it. So we had to take that into consideration when we were doing our modelling. So the results from the modelling quite clearly showed that although we had the required capacity to meet the demand, our waiting list was way above what the sustainable target should have been. So something needs to change. We're just not doing something right here, are we? We were getting frequent messages from staff that we just weren't considering the types of patients we were seeing. They kept reporting that patients had increased complexity. That meant that they were staying on the caseload for longer, which therefore meant they weren't feeling able to take on new patients. We also needed to consider the types of pathways. So we hadn't actually considered that we have an emergency pathway, very small demand, but a big drain on our capacity because we need to ring fence capacity for that. We also had a lot of complexity managing multiple different rehab pathways. We had care homes, we had social care staff, and we had just in our own home. So we needed to streamline that. We also needed to look at how we were using our staff and looking at the skill mix as well. So some of the immediate changes we made were to do with the DNA management. We had to enforce our DNA policy. So, and this was learning that we shared across other services as well. So we implemented the DNA policy more strictly. We also started to look at where our capacity was being lost in order to work out how we could improve productivity. We also had to look at how we were using our current capacity. So, was there any new ways of working we could implement, any different clinics, for instance. We also really needed to improve our data so we could start pathway modelling. So as you can see from the SPC graph, the impact of the change is quite significant there. We started with the orange dots, and as we move through the time frame, you can see that we've implemented changes along the way that has started to bring the waiting list down towards the sustainable target, which is there at the red dotted line at the bottom. We're still quite a way off the target, but what we have put in place has made a significant improvement, which is great to see. So some of the things that we've put in place along the way are, so we implemented the DNA policy, We regularly validated our waiting list. We introduced visual management. So that helped to, firstly, better utilise staff resource, but also staff had a better understanding of the patients that were on the waiting list. So they were able to kind of cohort patients together in geographical areas better, but also suggesting different types of clinics in order to manage that demand. So a lot of team-led as well as service-driven change. So the final piece in the puzzle for me was the pathways work that we needed to do, the pathways modelling. So I want to be able to understand the demand along each pathway, what's the complexity of the caseload, and what kind of staff resource do we need. So at the moment, our data system in EMIS, it's set to provide our data by locality and by staff member. We can also get some data by urgency as well, but we can't get the pathway data. So that's my wish list. We can record it as a reason for referral. It's not sensitive enough. However, we can actually input a diagnosis code, and then we could maybe group those into pathways. So that's where we're looking at now. We don't get any of this data in our normal monthly reports, but we are hopeful that we can start to do this in the future. Not being able to get this in our monthly reports, so hasn't stopped me trying to do some initial steps, if you will, in the pathway modelling. So I've done some audits of our referrals that we're receiving, and the top 2 diagnosis codes that staff were choosing were falls and frailty. These 2 codes make up roughly 80% of our total demand. So if we look in more detail at the falls and frailty pathway, there are 3 broad streams within this: an assess and discharge, a rehabilitation, and a high complexity stream. So within each of those streams, we then need to consider what's the skill mix required, what's the new to review ratio, and which profession may be best placed to lead on that pathway. So then breaking down each of those streams into the steps within the pathway. So we've got, say for instance, the assess and discharge pathway here. We've got 1 new patient plus or minus a follow-up and then a discharge. On the rehabilitation pathway, we've got a new assessment and then a number of follow-up appointments with a discharge. High complexity pathway will include things like MDT meetings, report writing, further follow-ups, and then another discharge. So the next step from that is to then look at the timings of each of those steps. So it might be that discharge for the assess and discharge pathway only takes 10 minutes because it's a simple discharge. The other pathways, actually the discharge step might take half an hour because we're having to do phone calls and report writing. So then the next step again there is looking at how many referrals are coming in on each of those pathways, which will then help to, if we know that 80% of our referrals are from these 3 main streams, we can look at more detailed demand and capacity planning, and then we can link that to job plans, which is the next step. So our future plans, I want to take this across our directorate. Obviously we've just done the community therapy team, but with a number of services within the directorate that would benefit from this demand and capacity modelling. And again, from the learning that we've discovered, I want to be looking at standardising our diagnosis code input and regularly getting that report into our reports so we can continue to review our demand on a monthly basis, quarterly basis. We need to be continually reviewing our data quality. Again, what goes in or what comes out is only as good as what goes in. So again, that's linking in with our admin teams, linking in with our clinical staff, and making sure they can understand the loop that we're that they're a vital part of. Need to get a better understanding of baseline capacity. Again, we've still got that challenge in the community therapy team of what is a baseline capacity. We will have a better idea when we have done the more in-depth modelling. But again, we also need to roll this out across other services as well, because currently there's I wouldn't say we had the baseline capacity set for other services, so we need to have a bit of an understanding there. We then need to be able to set up our job plans with this information. Certainly want to be understanding the different demand and capacity models. I understand our service will probably be better modelled on the high complexity model. For me, that's a little bit tricky, a bit of a challenge. I will get there. I will have a go, promise you. The final thing really is with a bit of a COVID-19 hat on. At the moment, we've done some rapid transformation based on the need to do things differently at the moment. Things such as remote consultations have been the forefront of what we've been doing within our therapy services, and I think this is something that we're going to be analysing in more detail over the coming months. And how does that then impact on our demand and capacity challenges, and does it actually improve things? We need to understand the steps in the process there as well, but it's certainly interesting times from a demand and capacity point of view.